there, I'm going to be giving a presentation on the National Patient Safety Goals. The goal that I've selected to present on is improving handoff communication at shift report or other transitions of care. The Joint Commission for Accreditation for Healthcare Organizations has identified as their National Patient Safety Goal number 2 to improve the effectiveness of communication among caregivers. Handoff communication is a key portion of this. The handoff communication can happen at shift change. That's a big time where nurses are exchanging information about patient care. The other points of transition of care can include transfer to an outside facility, transfers between departments, transfers from ER to the floor, from the floor to a nursing home or other long-term care facility. So, handoff communication is defined as the transfer and acceptance of care responsibility achieved through effective communication. So the participants in handoff communication are a sender and a receiver. Both are involved in exchanging responsibility and accepting responsibility for the patient's care and for providing good communication to ensure a good continuum of care. Breakdowns in communication, according to the Joint Commission website, were the leading cause of sentinel events reported between 1995 and 2006. So obviously, some of the adverse events that can occur as a result of poor or delayed communication, especially at handoff, can include delayed care, inappropriate treatment, increased hospital length of stay, or increased cost. The way that we go about fixing the problem of poor communication is by providing standardized handoff communication formats that decrease the errors and omissions that can sometimes occur that lead to the breakdown in communication that lead to adverse events for patients and poor outcomes. So a case study that we have here would be a patient in the ICU admitted for diabetic ketoacidosis, or DKA. So this would be a very complex patient, a typical patient admitted to our ICU here. She is awake, alert, and oriented, but unclear about the events leading to her admission. She requires labs every 4 hours, blood glucose every hour, and needs to have a PICC line placed because she has poor venous access. Patient has a history of heart failure and normally on fluid restriction at home. After fluid resuscitation for her DKA, patient is beginning to have respiratory difficulty. And patient has a Foley catheter placed in an outside facility that now needs to be changed per the hospital protocol. So on this very complex patient, what are some things that would be very easy to miss or omit during shift change report? Some examples that I thought of were that her Foley catheter needs to be changed. It would be very easy to forget to mention that for the off-going nurse to share that that Foley was not inserted here at our facility. It would be very easy to forget to mention when the next blood glucose is, which could result in a delay of care for that patient. It would be very easy to, neglect or minimize the respiratory difficulty that the patient is having, as well as whether or not it has been addressed by the physician. When are the next labs due for the routine 4-hour labs? What were the last results? And how are we getting these labs, since we know the patient does have poor venous access? And then the other thing would be possible PICC insertion that they're planning for this patient. Has a consent been signed? Is the patient willing to have it done? When is that scheduled to be done? So these are some of the things that would be very easy to miss at a shift change report if not done in the proper manner. So some suggestions for improvement for the poor communication that can often occur during handoff communication would be, number 1 would be for bedside report. Evans, Grunewalk, McClish, Wood, and Freese, in their article released in 2012, stated that communicating about the patient condition, nursing assessment, and required interventions at the point of patient care is what constitutes bedside report. So this is when nurses are at the bedside actually giving the report. This enables improved times for shift report, increases both patient satisfaction as well as staff satisfaction. It also decreases the likelihood of adverse events due to a change in status that may have occurred during the last time that the patient was seen by the off-going nurse and the initial assessment done by the oncoming nurse. It also allows patient care to begin sooner for the oncoming shift. Another suggestion for improvement for improved handoff communication would be to use the format of SBAR. As I'm sure most of us know, that stands for Situation, Background, Assessment, and Recommendations. It's a format used to communicate pertinent patient information between caregivers. SBAR is particularly useful when communicating between interdisciplinary teams such as nurse to physician, nurse to respiratory therapist, nurse to physical therapist, or any other ancillary departments that we interact with for patient care. It does improve communication by providing a standardized format in which all needed information is communicated, and it is less likely to omit or forget information that is pertinent to patient care. Using SBAR also has been shown to improve critical thinking skills because it does require an assessment and recommendation from the nurse, as well as improve situational awareness and sort of a big picture outlook on patient care. The final article that we're going to be referencing here is by Taylor, released in 2015, and it references bedside report with an added feature of having the electronic medical record available for the nurses at report and available at the bedside. The topic that was addressed in the article was called walking rounds, wherein the nurses are actually rounding on their patient with a computer or some type of device that had the medical record available. The Joint Commission actually recommends an interactive communication during shift report so that you're able to reference the most up-to-date information. Again, we know that bedside report improves patient safety and satisfaction, allows for efficient exchange of information because you have the electronic medical record right there, the patient right there to provide input, and it improves quality patient care and safety and maximizes effective communication. So we'll go back to our case study. So using the interventions that we had discussed, the bedside report, SBAR, and using the bedside report with the electronic medical record, we'll go back to our case study and see what some of the problems that could have occurred, how they would be corrected. The Foley catheter that needed to be changed per policy. It could be changed during bedside report with the assistance of both the offgoing and oncoming nurse. They get it done, it's done, and the hospital policy has been followed, labeled with date and time, and now that task has been completed. Has the physician addressed the fluid status? What is the patient's current respiratory status? Both nurses could be there at the bedside, assess the patient, judge whether or not the physician needs to be called, and during bedside report, they agree that the physician needed to be called, and so he is contacted and a cardiology is consulted to help manage the patient's heart failure and fluid volume status. When is the PICC insertion scheduled? Has the consent been signed? That information could be communicated during the situation and background components of an SBAR report. And then the consent could be obtained during the bedside shift report. So now that task is removed from the oncoming nurse's to-do list or task list. The blood glucose is due during shift change report. So while the nurses are in there doing bedside report, they have the electronic medical record available. They notice that the glucose is due, enter it into the computer, and again, now that task has been completed during bedside shift report. Finally, the labs that are due every 4 hours. We know with the electronic medical record that's available with the bedside report, we know that the labs are due in about an hour. The nurse that is coming on can go ahead and prepare to draw those and can go ahead and have that task ready to be done first thing that morning. So what all of these interventions allow us to do is, again, to prevent any delays in care that can occur due to poor communication. They improve patient safety and satisfaction by allowing interaction between the patient and family members and staff, and also provide decreased likelihood of adverse events that can occur due to poor communication. Thank you very much.